You're watching Problem Case Discussion, as easy as PQRST, produced by GP Supervision Australia and presented by Dr. Simon Morgan. We would like to begin by acknowledging the traditional custodians of the land on which this recording was produced, and pay our respects to their elders past, present, future, and their families.
My name's Simon Morgan. I'm a medical educator and the education manager with GPSA. I'm also a medical educator of the RSCGP and a GP here in Newcastle. And welcome to this webinar on problem case discussion and using this model, the PQRST model, of structuring an approach to how to really kind of make the most of this very, very common teaching and learning method. So really, in terms of what we're going to cover, and I'm hoping what this is going to do in many respects is just reinforce what you are doing in many respects anyway, but just apply a bit more structure to it. We're going to talk about case discussion more broadly as a teaching and learning method in GP training and the practice. We're going to talk about the PQRST model and how you can integrate that into your educational practice. There are lots and lots and lots of teaching methods, and this session is very specifically around problem case discussion and using this model. But I guess before we funnel down to that very specific bit of learning, I did want to just encourage this absolutely, vast smorgasbord of opportunities we have to teach our registrars. So a whole range of case discussion type activities on the left, topic tutorials when we're focusing more on conditions, demonstration, physical examination, procedural skills. Some of you might be doing audits with your registrars, and indeed they might be doing some teaching of their own with the students or of yourselves. Before I sort of focus in a little bit more, I just want to put a little bit of a plug in for one of these, which I think gets a bad rap, and that is role play. And that cartoon kind of really summarises both the registrars and I think maybe sometimes the supervisor's approach. It's, confronting, it's threatening, it seems artificial. And yet what I would encourage, and I do encourage, is not to shy away from it. The registrars may, try to discourage it. And also not to focus on a sort of 10 or 12 minute lengthy discussion, but really just to say, as part of almost every little bit of teaching you do, let's just role play this for, 20 or 30 seconds. How about you just pretend I'm the patient and you explain the diagnosis of carpal tunnel to me, or I'm the mother of this child with bronchiolitis. How about your safety net? How would your safety net with me enroll? And I think just incorporating role play into everything you do, direct observation discussion and RCA and of course problem case discussion, can really, really help the registrar. And of course, they're going to be doing this in their clinical exams. They'll be doing role play with artificial patients, and so it just helps them get more and more confident in that. I think it's just important to say all these things are actually case discussion. I mean, it's one thing to say, I'd like to talk about Mrs. Smith who's got a headache, but the other thing is, if you look at some pathology results, or if you talk about prescribing audit, or if you look at a referral, it still is a case discussion. You still open up the patient, start talking, and you can do all the usual things, talk about clinical reasoning and think about professionalism and communication skills and the rest of it. So it is actually all case discussion. All right, but this is really just kind of thinking broadly before we move into this very specific but very common teaching and learning method called problem case discussion. And I don't know that it's really had a name up until fairly recently. It's just that thing where a registrar says, I need some help. And in fact, when you think of all those case discussion methods, most of them are supervisor generated. I'm going to sit in with you. I'm going to look at your notes. The college has asked me to do a formative assessment activity. But these are registrar initiated. They're registrar driven. The registrar has an issue and they're coming to you. It may be complex. It may be urgent. It may be in the context of a corridor consultation or a bit more leisurely in a teaching session. But either way, it's registrar generated. But the point of this session really is to move beyond what I guess maybe traditionally or maybe we default to doing, which is here's the answer, to really unpacking it and making the most of this teaching moment. I think the point is, and why I authored the paper now a couple of years ago, and why I'm even bothering with any of this is I think my observation is, and registrar's feedback is, sometimes the PQRST complex, the nice, organised, structured approach to learning, is a little bit all over the place. And to elaborate on the ECG analogy, maybe the whole PQRST complex gets lost and it's just this sort of chaotic, I haven't got time, or what do you think? And it's trying to apply a bit of a structure can help. It's hardly rocket science asking before telling and exploring that with the registrar, but it is actually so commonly overlooked, I think, particularly in the corridor consultation, but even when you've got more time, those sort of specific steps. And all this is about is giving you that framework, just unpacking that a bit more. So some of these formal approaches which have been discussed, ask before tell, that's the most basic one. If you do nothing else, it's just saying to the registrar, what do you think, before you might proffer some sort of response. I mentioned other more formal techniques, which I'm not going to go into and I'm not going to describe, but you can look these up in the literature if you're interested. The 1-minute preceptor, which is American, it sounds American, with a preceptor, and it's also called the 5-step microskills model. And it's one that's been taught over the years to Australian supervisors, but it in fact was described for hospital residents in American outpatients. So, in some respects, a different model and a different setting to Australian general practice training. There's the SNAPS approach, which sounds almost a bit like a German sort of a liqueur. And then I mentioned Jared. Jared wrote this paper. Again, if you Google www.doc, Jared Ingham, you will come up with his paper, which was describing an approach when the patient's in the room. But really, there was nothing for general practice training. And I have been accused at times by Jared, of all people, of sometimes my tail wagging my dog. And he would argue that I was driven by the acronym PQRST over the actual approach. And he would argue, and if he was sitting here, he'd be saying, Simon, I still think this thing should be called the QPRST. And in fact, after I've finished, you may think the same thing, but that's kind of okay. And it's a good time to say to you, if you think the only bit of this whole model that's useful is the Q, or it should be PRQST, whatever you like, I don't mind. It's just sort of thinking about it a little bit more and how it's structured. It's about this point, I think, is this the emperor's new clothes? Is this just some kind of new acronym that, in fact, it's describing what everyone's doing? Some of that's true, I think, but some of it actually, I think, has some value in just thinking about it as a nice sort of structure. And what does it stand for? What's the patient's problem? What's the registrar's question? Where's the registrar fit in terms of their capacity to reason? What's the solution? I think that was the hardest letter to come up with, but solution's not a good word because it's not really a problem that requires a solution. It's much more a plan of management, but I couldn't think of a better S word. And of course, what can be taught. And happily, we're very, very familiar with the PQRST complex in ECG interpretation, and it seemed to fit. I ran a session on ECG interpretation recently, and very interestingly, when the first electrocardiographs were developed, I think in the late 1800s, in these extraordinarily complex systems of people dunking their limbs in electrolyte solutions and this huge big kind of machine in the background, it was called the ABCDE complex. And for some reason it changed. So I'm glad in a sense it wasn't, because that would have made this even harder. But let's sort of describe those things. And again, maybe just putting a bit of an academic slant on some of this. So the first thing is this: there is a described approach to case discussion called problem representation. And you'll see that written up in the literature. And it's not just a nicety. It's not just a kind of helpful thing for us as supervisors or educators to get a nice clear summary. It actually really helps the registrar reason and refine their reasoning, because they really need to be succinct. They need to describe the patient. They need to describe the illness, and they need to describe the sort of temporal pattern. And I think, as you'll see, it's absolutely fair game for you to pull your registrars up or indeed have a conversation and say, this is how I want you to present cases, as if you're talking to a snarky orthopedic consultant on the phone and you're a sort of hospital resident. Now, that's not exactly what I mean, but I think nature of I've got my this opportunity to talk to my supervisor. I really need to kind of consolidate my thinking and really present it well, including what I want. Not I need some help or I don't know what to do. It's is it diagnostic? Is it management related? Is it which tests? What exactly do you want to know? And the other thing I think that James Brown spoke to in some research he did, which I just think so eloquent and interesting, and we should hold in our thinking when we explore this with registrars, is not just what's the question, but why is the registrar asking me this? Are they Browning again? You know, they're just, which is might be absolutely reasonable if they're a GPT-1 and it's their early weeks. Are they just, I don't know, no clue, and they are actually saying, I don't know even where to start? That might be entirely appropriate, less so from a more senior registrar. Or are they seeking assistance? Yeah, I'm kind of, I think I know what to do, but I'd really like your help. Or they're actually managing the case very well. They've got a really clear approach, but they're just wanting some reassurance. And I think thinking about how and where they sit on that schema can be helpful too, when the reasoning exploration is possible, because clearly I think this model is appropriate and useful and can be applied for corridor consultations, even when you've got a couple of minutes, give me a quick snapshot. What's the question? You're going to get a sense of their reasoning, even if you don't ask or elaborate questions. And then, what do you think we should do? Great. Yeah. And maybe have a look at the guidance. But if it's a bit more time and you've got a bit more opportunity to explore all these aspects of reasoning that we've talked about before, how well they generate a differential, are they managing uncertainty, how well they're weighting information, are they sharing the decision around that management with the patient, are they communicating it well, all that sort of stuff. So reasoning very prominently. Of course, they're asking us for help because they need assistance, and we do need to provide that. Even if we don't have an answer, we might provide some wisdom, we might provide some guidance, we may try to identify where the gaps are, including asking before telling, and of course, what can be taught. And that might be, you go off and have a look at the guidance, and maybe we can talk about this at a teaching session in an upcoming. As I've presented this session a little bit in the last few weeks, I sort of think, is this really just kind of putting a name to some of this? But no, I think if we can, this is the model we use and how we apply it, I think it can be useful. We're going to watch a video, which is role played, of a GPT-1 registrar called Claire, who is a few months into her term. She's a capable registrar. She's working in your practice. Oh, well, my practice, I'm Adam, I'm her supervisor. And it's a regional, large practice. And she's going along all right. Certainly not the best registrar I've ever had, but safe and effective. And this is kind of attempting to demonstrate the model. Jess and I thought we would run a little bit of a role play, but we'll try to make this the sort of context of a problem case discussion at the end of the day. Claire's a GPT-1. She's maybe 3 months in. She's going along okay. She certainly recognises her limitations. Her knowledge base is reasonable for a registrar of that experience. And she's probably a little bit anxious on the scale as it goes. Claire is seeking my guidance as part of the sort of end of the day discussion. Oh, hey, Claire.
Oh, hi. Hi, Adam. How you going?
Yeah, good.
I just, have you got time? You don't have to rush off. Just want to ask you about a patient.
No.
Yeah. I've seen a girl twice now. Kalia Kyle. I think you've seen her family before. Anyway, I've seen her twice this month, and she's had about 6 months of kind of, tummy pain that just keeps coming back, and Mum's really worried about it because she's missing a bit of school and it's not really clear what's going on.
Hey,
and I just...
I might stop you there if that's okay. I went to this webinar the other day about how to sort of make this a bit more sort of structured. I'm going to give this a bit of a crack, but there's this thing called a problem representation. Do you remember we talked about that, how to kind of just succinctly give the case?
Yeah.
Can you maybe start again and just try to give those key features and the illness description and things?
Yeah. Okay. Yep. So Kalia is an 11-year-old girl, previously well, who's got a 6-month history of recurrent episodes of central abdominal pain, which is sharp and intermittent in nature, and it lasts for a few days to a week, happening every few weeks, sometimes associated with diarrhea, but no PR bleeding, no periods yet, no significant family history. And I mean, looking at her, the 2 times I've seen her in the last few weeks, she looks well. Her tummy's soft, but just kind of generalized tenderness everywhere. I did on the first visit request stool culture, which was negative, an OCP negative.
Excellent. Thank you. So that's a nice problem representation. I've got a bit of a sense of her now. The next thing's the Q. So tell me, what do you want to ask me about particularly?
I'm just not sure about investigations. So I was wondering, should I be doing more or potentially more invasive investigations now, and what ones?
Yeah, and that is it's always a bit of a challenge in children, I think, and this kind of scenario. So what I wouldn't mind doing now is maybe just unpacking things a little bit and getting a sense of your understanding of the case. So thanks for the history. You gave me a good history. What other features might you need to consider? What other features on history, perhaps, that you might not have mentioned to me? Or
I can't remember if I mentioned. So she's had a little bit of diarrhea occasionally. She hasn't had any vomiting, and her weight is okay. So she's kind of always been above the 50th, just above the 50th for height and weight, and that's still where she is. So she hasn't lost any weight, and she hasn't had any night symptoms either. So
great. So you've given me some negative red flags, which is great. Were there any other red flags that you asked about, or you need to think about?
Yeah, so there's no weight loss, no bleeding. She hasn't. I did ask about like fever,
Right.
which she hasn't had. No rash, no joint symptoms, no eye, pain or redness or anything like that.
Oh, excellent. Yeah. Good.
Yeah.
And have you mentioned family history? What sorts of things were you specifically
I was mainly thinking about like inflammatory bowel and celiac were the main ones. Yeah, which there isn't any known history of that. Mum was quite concerned, about her pain, which is kind of, and then that was what made me sort of think, oh, is there something going on in the family? But I'm just thinking about other red flags, and with her, the intermittent diarrhea, I just realized now I haven't really established how often that diarrhea is happening and what her kind of regular bowel or normal kind of bowel pattern is.
I think that's a really important question to ask it around diet, around normal bowel habit and that sort of thing in a child like this. There's another big area of history that I think important that you may have touched on, you may not have. And that sort of psychosocial stuff. Did you explore any of that?
No, not really. I mean, Mum just mentioned that she had missed a few days of school because of it, but I didn't really ask much more about that.
Okay, yeah. So I'm curious. She said, well, you told me that she's having episodes where she's quite well in between. How much weight do you put on that in terms of your sense of something concerning going on?
I guess, I mean, I think it's kind of reassuring in a way that, she does get better, but obviously with things like inflammatory bowel disease, it can be very episodic. So that feature alone, I wouldn't be kind of comfortable that means that everything's fine.
I think that's excellent. That's a good way of considering it. And I guess, so at this point, what would be your differential, Claire?
Yeah, I guess I'm wondering about celiac disease just because, I don't know, unless I just didn't write it down, but I'm not clear on, any association with certain foods or diet, that sort of thing. And again, I haven't really established what her bowel habits been like other than these few episodes of possible diarrhea. So I guess, constipation is always a thought. Inflammatory bowel disease is possible. I guess I'm reassured by the no blood and that her weight's okay. Yeah, whether it's like an irritable bowel or some anxiety thing, like you mentioned the psychosocial stuff, like I haven't, like, yeah, I wasn't, yeah, I just guess I wasn't sure, like, I mean, I didn't want to pin it on that straight away, but I wasn't sure, like, where's the line for like doing bloods or that kind of stuff.
Hence your question.
Yeah.
Good. Look, that's really helpful. I think I've got a bit of a sense of the way you've interrogated the case and thought about it and your approach. I always get a little bit uncomfortable at this point of this framework with the S, the solution, because often I don't think I know the answer, but I'll certainly help you in the best I can. I guess I've got a few thoughts, but I'd be keen to get your sense initially. What you're asking about investigations, what's your sense? Do you think she probably should proceed to have some tests at this point or not?
Yeah, well, I went on Health Pathways to see if that had anything, but there wasn't for, kids with recurrent tummy pain like Kalia's. Yeah, I don't know. I don't feel like she needs to do bloods. Like she looks quite well and there's not red flags there, but I guess I'm just, I don't know, mum's really worried and I guess I kind of then feel worried. I don't want to miss something major. I'm pretty sure I remember that x-rays aren't really useful, but I haven't actually checked.
So you touched on two really nice things, I think, as part of your reasoning, and that is one, that you've got a gut feeling that things are okay, which we can't rely on wholly, but that can help guide us a little bit. And secondly, that the mother is worried, and that can lead us to do tests when they're not indicated, but it can be an important guide. Do you have any other sense of evidence-based guidelines that we might go to?
Yeah, I just remembered, I think RCH sometimes have good good things for kids.
They do actually. They're excellent. And in fact, let's have a look. And there's a good chapter on abdominal pain, and they do talk about an organic and functional type categorization. And your differential was pretty good, I think. We talked about red flags, and look at that, they're in red and bold. So that's nice, and you covered most of those. And some of those other aspects of the assessment, I think. I do think, as you can see, a head screen there. So the sort of psychosocial aspects of carer, I think, of her background are really important to identify.
Yeah.
And yeah, I think just broadly speaking, investigations, most children don't need any investigations and should be targeted to the likely diagnoses. And there's a list of possible tests there. You're right about the imaging, that it's probably pretty low yield. That said, I think a urine test is always easy and reasonable to obtain. So my sense here, Claire, is it's probably not unreasonable maybe to get it back and maybe explore some of those other aspects of the history. I like to share the uncertainty, but also share the low yield of tests. And, we always have to think hard about doing investigations in children. I don't know that there's an urgency at this stage, and I think, but maybe explore that with the mum. Did you actually get a sense of why she's worried about anything particular?
I think it was more just because she was missing school, and then she gets better, and then it kind of happens again, and I think it was more just because she's not sure what's going on.
Yep.
But yeah, maybe I'll get it back, and I definitely need to ask a bit more about the intake and output kind of patterns. And maybe just do another weight check or something just to kind of get a good chart that over time and stuff, because that can be fairly reassuring, I suppose.
Excellent. So the last step's the T, and I think we've hopefully talked a little bit about, I've certainly learned a bit myself just looking at this, but the teaching side of things. I really like the sort of general principles that RCH often have, and here in most children, no organic causes found. I really like this notion that non-specific abdominal pain in children is a diagnosis to be made, and we don't need to exclude everything else. It's a bit like IBS. So, we can make a positive diagnosis and we don't have to do a whole bunch of tests to exclude everything else. And most kids, in the absence of red flags, this pain's likely to be functional. So they're good general principles, I think. But how about, do that and we can discuss this again once you've seen her.
Yeah. Awesome. Thank you.
And certainly I think she does need investigation if things aren't settling or things are getting worse. But I think
I'll make sure I
now
have a safety net and stuff. Yeah. Thank you.
Great. All right. Thank you, Claire. Thank you. I don't know, but probably we should have timed that just to get a sense of how long that took. But I don't know that that was particularly different to the kind of time you might spend exploring problem cases with the registrar, particularly when you're taking a focus on reasoning assessment and teaching. That's a version of a kind of a more structured approach. What can I say to you, Claire/Jess, in doing that? I mean, I had a very clear sense of your patient. I think that sense of a kind of disorganized history is very common, and to pull a registrar up and to say, no, please try to do it as a problem representation. That sort of stem is essentially a problem representation.
So obviously that was quite an elaboration of the method. And, if you've got 2 or 3 or 5 cases to get through, you're probably not going to go into that much depth at all. Certainly if it's a corridor type consultation, you're not going to get anything near that. But yeah, just to elaborate and trying to kind of demonstrate some of the reasoning stuff as well. I guess in role playing, I was attempting to kind of, ask some of those questions that really help unpack that around weighting of information. So, she'll say, or we can identify episodes between the pain where she's well. Is that reassuring or not? Is the fact that she's not losing weight reassuring, or indeed the opposite? Is a fever in this situation particularly worrying, or would you expect that, or whatever the case might be? Just, I guess, in summary, this is just quite a kind of defined, discrete educational activity around this particular model. Why was it conceived? I mean, it was conceived on a train, actually, returning from a workshop I ran with some supervisors in Liverpool, and I was going back up to Central. It's about an hour, if anyone knows that train ride. And we had been talking about the 1-minute precept, and I must say it just sounded so kind of disconnected from the experience of what we do as supervisors with registrars in the practice, that I thought, well, what are the issues here? Where could this approach be strengthened? And of course, all of you are probably thinking, well, it's kind of pretty close to what I'm doing. So in a sense, what it's doing is just describing a framework. So, maybe for a brand new supervisor, or indeed somebody who's been around the block a few times who just would like to sort of fall back onto, oh yeah, that's that PQRST thing, certainly means that question's very paramount. And it's not just about us being able to answer the question, it's about the registrar being able to identify the question, which is so important. The R does allow us, I think, and overtly and expressly, how well is this registrar reasoning? And of course, as supervisors, we're thinking and assessing that all the time. But if we actually bring it to the front of mind and make it prominent and say, reasoning, what questions can I explore here to get a sense of whether this registrar is seeking information, weighing up information, synthesizing information, communicating information, how well they're doing. Obviously, it's identifying registrar learning needs, but also patient safety issues. And yeah, I mean, I think it is something that we can use for the really struggling registrar in a supportive kind of nurturing way and not overwhelm them, but also push a capable, high-performing registrar as well. What we've covered in thinking about the session, we've thought about the breadth of learning and methods. And of course, if you're interested in any of those, we've got resources on the website and we've done webinars on that. But focusing in and funneling down from that sort of breadth of interesting activities, that many of which are case discussion. You open up a pathology inbox, you see a full blood count, you ask the registrar, tell me about that patient, they explore it, you talk about the patient in the context of the pathology test, but of course you then start talking about the case. They're all case discussion. We're talking specifically about problem case discussion and ad hoc supervision when the registrar is initiating it. And then we've talked about this model that hopefully you can apply. That is the reference, and it really is a simple HAGP article that I wrote up, and essentially what I've done is elaborated on that, but you might wish to read it. I'm a great believer that the things we do as supervisors should not be kind of hidden behind the curtain for registrars. So, print this thing off or give the link to the registrar and say, this is how we're going to do it from now on, if you think this sort of model works, and this is the reasons why, and you have a read of this and see, that I think it's going to help potentially the way we interact when we do problem case discussion. So these are a couple of the how-to resources that we've pulled together over the last 12 months or so. These are designed to be very brief, punchy, simple, almost sort of, recipe-style guides to do teaching activities in the practice with registrars. So one on PQRST, one on this problem case discussion method,
and another one on teaching clinical reasoning, which of course this is a method of exploring and teaching clinical reasoning as well. So you might want to have a look at those. That is not a nice, organised, structured electrocardiographic complex of PQRST. It's a pretty awful tattoo as well. But I guess the whole point of this was to achieve a bit more structure in the way we undertake this activity with registrars. It is lovely to have you along. All the very best. Thanks. Bye-bye.
Thanks for watching. We'd love your feedback. Please comment or subscribe to our YouTube channel for updates on new videos. If you'd like to ask a question or suggest a topic, you can contact us via our website at gpsa.org.au. GP Supervision Australia is supported by funding from the Australian Government under the Australian General Practice Training Program.